So this week moves into health disparities and social determinants of health. And our weekly sessions will end on July 14th. So after July 14th, we'll be moving to a monthly maintenance session. And during this maintenance session, we'll be kind of tailoring the curriculum to meet your needs and see, we're really curious what you would like addressed. So I'm going to launch a poll, if you could, and if you could just give me a little bit of feedback about what topics sound good to you, and then we'll be taking this back to the team and kind of establishing the curriculum for the next part of our maintenance phase that again starts the first Thursday in August on August 4th, and then we'll have monthly sessions on the first Thursday of the month, and we'll continue to send out reminder emails. We'll continue to introduce different support for you and your staff and your residents, and we'll be introducing some curriculum and some programming for your residents as well in the coming weeks. So looks like several of you are chiming in with your preferences for some of the upcoming maintenance phase topics. It looks like falls prevention is doing really well here with 5 people saying that falls prevention would be helpful. Advanced care planning, behavioral health for residents, for staff. It looks like there's several polypharmacies also getting some love there. So we will be looking at your feedback, and we'll be maybe gauging your interest over the next couple weeks as well to kind of craft that maintenance phase, the curriculum, and what we're providing. So we really do want to provide you with topics that are beneficial for you and your residents. So thank you for filling out that poll, and I'll take that definitely back to the team. So Barbara, if you want to advance the slide, and I'll turn it over to Dr. Yankilov.
Hi there, everyone. So we are going to be sending out an advanced care planning data request. And so as being a partner in the Flourish Connect initiative, we will be delivering some information on advanced care planning in the maintenance phase, as you just saw as one of the topics that is going to be talked about. And so the idea here is that we are going to be doing a baseline data request. There will be some training, and then we'll be asking you to complete this data request again. The actual survey is going to include a variety of things. It's going to ask you what are the number of residents that are 65 plus in your skilled nursing unit. That's the first thing it's going to ask. It's going to ask you to tell us how many residents that you have an advanced care plan documented in the medical record. That's number 1. Number 2 is how many residents who do not have an advanced care plan, but do have a surrogate decision maker documented in the medical chart. And number 3, the number of residents with documentation in the medical record that advanced care plan was discussed, but the resident did not wish or was not able to name a surrogate decision maker or provide an advanced care plan. So it's going to ask those 4 different questions on this particular Qualtrics survey that's going to come your way, so we get a sense of the advanced care planning that's going on. Let's see, why don't you do the next slide? All right, so how's this going to come? It's going to come by way of email. The lucky ones to receive this actual data request is going to be the nurse administrators and or the data analysts that were identified on the orientation survey that we did way back when. Only 1 individual is going to be needed to complete this, so you guys can draw straws. It may end up going to your trash folder. Don't get excited about that. We want you to find it so that you can complete it, because it is going to be coming as a mass request to many individuals throughout all of the nursing homes that we've worked with in Project Connect. So the way to look for it or find this particular data request is actually search for it in your email. And if you're anything like me, it is often kind of amazed to see all of your emails. But the regarding line should say Flourish Connect data request. And we are asking that you go on and complete it on July 13th. So in about 2 weeks, we are offering for this. And then I think that might be my last slide. Oh, okay. So when is it going to be coming out? It is going to be coming out today. Again, look for that regarding. Go look in your trash, your unfocused, as well as your core inbox. And you'll just see that's what it's going to look like to the right. It'll have a few questions about your name. It'll have a question about, where is it that you guys keep your advanced care planning information, whether it's in the medical record or on paper. And then it'll ask these particular questions where you'll go on and put a number in there. And then if there's anything you want to share with us, there's a question for you to go on, an open-ended question for you to do that as well. So is there any questions that you have? We can talk about, maybe we have a minute here to discuss, as well as you can send an email to myself, pam.yankeelove@louisville.edu, which is on one of the slides. I think it's on 2 slides up, as well as you can also, there it is, as well as Ellen Roberts. So you can reach out to us if you have any questions. It's also in the actual survey. When it comes to you, you'll say, they'll be in there saying, if you have any questions, you can reach out to us. Okay. And I'm going to be hanging around. So if you have any questions in the chat, or if you have anything you want to share, you just let me know. Are there any questions now about it? How it's going to come? When is it going to come? When is it due? Hopefully those were the things, the who, what, when, and where, and everything I was trying to get at. All righty. Thank you. Oh, is there somebody typing something? Let's check. There we go. All righty, great. Thank you so much, everyone. Do you want me to go through this one?
I got it. Thank you, Pam.
You got it. All right. Thank you.
Yeah, and as always, we have a short session survey at the end of today's session. This will be week 22. And today's presenter has nothing to disclose, so I will turn it over to Ms. Barbara Gordon.
Good afternoon, everyone. So happy you are here. We are all here together. We're going to be talking about diversity, equity, and inclusion in nursing homes this afternoon. Very important topic. You may be asking, why do we want to discuss this? It's a very important topic for us to discuss for a variety of reasons. And our goal today is just to foster equity, to discuss how we can foster equity in our nursing homes. So, as you know, over the past few years since the pandemic unfolded, and a significant racial, social unrest has occurred in America. There's been, turbulent times and an awareness, if I could use that terminology, of the need to expand diversity, equity, and inclusion into mainstream culture. It's come to the forefront in many environments, organizations, et cetera, and health care is not excluded from this particular area of focus and concern. The realization that we have not done enough has been recognized by many industries, including healthcare. It's not that we've not done anything, but we've not done enough. And that has been recognized in a number of ways. And we'll discuss some of those things this afternoon. But what does that all mean? I'm going to just share some brief, very, very succinct definitions of diversity, equity, inclusion, and we'll also include a definition for health disparities, because as a result of our systemic issues, concerns, problems, whatever we want to call it, with diversity, equity, inclusion, we know that there are disparaging practices in our healthcare system and many inequities. So diversity is the presence of differences within a given setting. It can describe differences in race, ethnicity, gender identity, sexual orientation, age, socioeconomic class, religion, language, disability, political perspective, etc. There are many other categories we can include there. It's important for us to provide this definition because, often when we talk about diversity, equity, and inclusion, we focus on race and ethnicity, and that's very, very important. And definitely, you'll hear me talk about that some more during this presentation of the issues of race in our country and systemic racism, specifically in our healthcare system. Equity is the act of ensuring that processes and programs are impartial, fair, and provide equal possible outcomes for every individual. Equity and equality are not synonymous. Equity looks very different than equality in the basic connotation of each of those terms. I'll probably expound a little bit more on that too as we go through. And inclusion is an outcome to ensure those that are diverse actually feel and or are welcome. You're included, you feel included. So what about disparities? I like to also offer a definition of disparities, as health disparities often is the outcome when inequities exist in our healthcare systems. Healthy People 2020 defines a health disparity as a particular type of health difference that is closely linked with social, economic, and or environmental disadvantage. Health disparities adversely affect groups of people who have systemically experienced greater obstacles to health based on their racial or ethnic group, religion, social economic status, gender, age, mental health, cognitive, sensory, or physical disability, sexual orientation or gender identity, geographic location, often also result in health disparities, or other characteristics historically linked to the discrimination or exclusion. Although the term disparities is often interpreted to mean racial or ethnic disparities, many dimensions of disparity exist in our country, particularly in health. If a health outcome is seen to a greater or lesser extent between populations, there is disparity. Race or ethnicity obviously is one of those areas in categories of disparaging practices. However, we know in our healthcare system, and particularly in long-term care, that sex, sexual identity, age, disability, social economic status, and geographic location can also contribute to an individual's ability to achieve good health. It is important to recognize the impact that social determinants have on health as well. In our next session, we'll talk more about social determinants of health. Health disparities exist in long-term care as well as in the community. So when we talk about our healthcare system, obviously long-term care is included in that. Disparities in healthcare typically result in the interplay of insurance, healthcare access, health literacy, and cultural disparities, including those that I listed as we define diversity, as well as we define health disparities. But also we need to remember and recognize geographic location, geographic distribution, et cetera, are also, they also play in this area of disparities. Residents in nursing homes complicates the situation since it introduces facility differences, regulations, and payer issues. So you can see and note that when we begin to talk about diversity, equity, and inclusion and health disparities, that there's an intersection of many different components. So what have we learned as it relates to issues surrounding equity and COVID? We've actually learned quite a bit as it relates to COVID-19. It's pretty much brought to the forefront many issues related to diversity, equity, and inclusion. It's you know, it sort of, I can use this terminology. I think it is a good analogy. The sheets were pulled down, the covers were pulled down as it relates. It's not that any of these things were new or that they weren't occurring before COVID-19, before the shutdown, before the pandemic, but they were definitely exposed. And as you see here in this slide, we're just providing some data, some statistics to help demonstrate some of the impact. The 2021 statistics show that 5% of COVID-19 cases and 36% of deaths were in COVID-19 deaths were in nursing facilities. We know the significant and serious impact that COVID-19 had on our long-term care facilities, on our nursing home industry, and it was very significant on the resident, but also on staff as well. And those nursing homes serving populations significantly composed of African American and and Latinx patients have been twice as likely to face a COVID-19 outbreak compared to facilities with the majority of white patient populations. And as I indicated earlier, and many of the issues that we really began to recognize and that came to the forefront, that was exposed in the media, et cetera. Many of these issues were there prior to COVID-19. Nursing homes that rely on Medicaid payment, which are, which are lower than Medicare and private payer rates, have long struggled with interlocking challenge of financial insecurity that in turn undermines professional staff recruitment and capacity. I know that many of our nursing facilities are from North Carolina and Kentucky, and we know and understand the impact of the different payer rates within nursing facilities and their ability to staff appropriately, as well as meet many of the criteria and standards across the United States. And that's a policy and systemic issue. The difference in the payer rates creates a problem. And there are a number of things that need to be done, a number of advocacy challenges that exist in terms of getting that changed. Across the United States, nursing homes with lower staff to resident ratios are more likely to serve Black patients. Furthermore, more severe quality problems were experienced by nursing homes that disproportionately serve Black residents. That existed during the pandemic, but again, the emphasis here is that those issues were present prior to the pandemic. All of these structural and systemic issues have implications for both residents and staff. And I do, this presentation is obviously going to provide you with information and data that relates to the resident, but the staff are critically important when discussing diversity, equity, and inclusion. So let me dig in here a little bit, just focusing in on the reality that we are dealing with and we are addressing today: diversity, equity, and inclusion. This quote I use quite often when I have this particular discussion because it just enhances, I believe, all of our desire to make sure that we are providing the best service possible to the people that we serve. And if we have this frame of reference and understanding that in our American healthcare system that we have some issues, then it is more likely that we can move away from inequality, inequities, and injustice in our healthcare system. Of all the forms of inequality, as Martin Luther King states, injustice in healthcare is the most shocking and inhumane. Everyone should have access to healthcare and should have access to equitable healthcare. Is the American healthcare system inhumane? That's a question we should ask ourselves, even for the organizations, practices, nursing homes that we work for. Is it inequitable, unjust? Does it not address diversity? Is it not inclusive? And these are questions we should ask ourselves, even as we practice in the environments that we practice in. What does the current data about health inequity and health disparities in long-term care mean for us today? So here, I'm sure you're familiar with, because we've been talking about the 4 M's, age-friendly health system, since we started this partnership with each of our nursing homes participating in Flourish Connect. The 4 M's are very, very important and very critical to the work that we do. And it's important for us to remember and understand that I believe that they do align with our discussion around diversity, equity, and inclusion. What matters most: mobility, application and mentation. And I'm not going to read this slide and all the information on it in those particular categories again, because we've talked about it often. We've integrated age-friendly health systems throughout our discussions about a number of different topics, because age-friendly health systems is very relatable in all of those areas. But I do want to walk through aligning age-friendly and DEI, age-friendly health systems and diversity, equity, inclusion, aligning it around the principles and the philosophy. As we consider application of the 4Ms in long-term care, it is important to emphasize that 4Ms is not a program. Often when we have creations like this, is looked at as a program that you have to implement, but it really isn't a program. It is a shift in care. It is a philosophy and a mindset, a shift in how we provide care to older adults. That is really important for us to focus on and emphasize. And as we think about age-friendly health systems, there are two key drivers of age-friendly care: knowing about the 4Ms for each older person in our care, and that's to assess that person, and incorporating the 4Ms into the plan of care, that's to act on. If you look at those categories in the slide that you see here, you'll see that assess means knowing about the 4Ms for each older adult in your care, literally knowing and understanding what each of those categories mean to that person, regardless of who they are. And then to act on that is to incorporate the 4Ms into the plan of care. Both must be supported by documentation and communication across settings and disciplines. Inherent in the 4Ms is diversity, equity, and inclusion, in the concept of anti-racist practice. How can you know what matters most to a patient without considering who the person is, without considering their culture, what culture they come from, what culture they existed in, without understanding and knowing about their lived experience? And then we can go on and on and on, listing other categories that are important to knowing the people that we serve. So consider diversity, equity, and inclusion in each of those categories. When you look at diversity in relation to the 4Ms, we want to consider the uniqueness of each patient. And in considering the uniqueness of each patient, we are responding to that part of the 4Ms that identifies what matters most. But we're also, if we're considering that person, we're also considering the other 3Ms, medication, mentation, and mobility. And yes, within each diverse category, depending on the experience, the lived experience, the culture, and where that person is at that particular time, then you're considering the diversity of that individual. Equity, facilitating the attainment of the highest level of health for all people. Again, you cannot consider the 4Ms without having a frame of reference around equity, around providing equitable care and service to the people that you serve, again, in every aspect of the age-friendly health system philosophy within the 4Ms. In inclusion, assuring patients feel valued and like they belong, assuring they have a voice, assuring the presence of a diverse healthcare staff, assuring the existence of a nursing facility, a nursing home that is inclusive of every individual who lives in that nursing home, but also works in that nursing home. So how do we create change in our nursing homes? How do we create change as it relates to diversity, equity, inclusion? How do we create change as it relates to eliminating health disparities and making sure that our practices are not disparaging? I like to utilize this aspect of a journey that begins and continues, consistently rotating through acknowledgement, action, and accountability. It is not a stagnant journey. It's not one that starts and stops or one that is ever finished or complete. The American healthcare system, including long-term care, has experienced many advancements and is much improved than it was 10 years ago. But we know that it is still in need of much transformation, especially as it relates to diversity, equity, and inclusion. If nothing else, the pandemic demonstrated for us that there is much more work to be done. And from my perspective, I believe it is continuous and eternal work, and it is never done. We'll be working in this space probably the lifetime of each of us and well beyond. This requires acknowledgement that change improvement is needed. And that's that first step or prong of this particular replication or example of systems change. You have to acknowledge that change is needed, acknowledge that improvement is needed, and then action, being intentional and deliberate to effectively facilitate change. Accountability, to assure that we never become satisfied or stagnant, accepting status quo or mediocrity when it comes to assuring that all citizens of our communities receive the best healthcare available. And when we consider this, especially when you begin to talk about diversity, equity, and inclusion, when you begin to talk about, creating an anti-racist system, anti-racist healthcare, anti-racist nursing home, it's not always easy to confront. It's not always easy to actually work in this space, listen in this space, accept this particular space. But it is definitely doable. And I believe, again, that all of us are working towards making sure that we provide the best healthcare that we can for all the people that we serve. And it is our goal to transform healthcare. To transform it, we must acknowledge, again, that first step, the trauma of systemic racism, and work together to solve it. We must acknowledge that our healthcare system is a racist system. It's not an easy thing to say, but it is been demonstrated, not just by people's own experiences and sharing that anecdotally, but also by data. Data supports this particular fact. Part of acknowledgement includes understanding where you are currently, which requires honest assessment and evaluation of yourself and of the system, the environment that you're working in. It requires open acknowledgement of a commitment from leadership to work together to influence and impact change. And obviously, it requires action. And action must be intentional and deliberate. This is a terminology that I use often. My colleagues say I coined it several years ago, but intentionality is absolutely necessary, and being deliberate in the actions that you take are very, very important. And in this is the reality that this is not an easy thing to do in the area of diversity, equity, and inclusion. This reality is not easy to accomplish in a very complex organizational structure, which many of our healthcare organizations are. They're very, very complex. Healthcare in and of itself, just generally speaking, from the national level all the way down into our own practices, wherever it is that we're practicing, whether it's a primary care clinic, university level like me and my colleagues are working in, or in nursing homes, which many of you are practicing in. One of the first actions necessary for any of our organizational structures is for leadership to acknowledge the existence of these complexities and understand how they impact the staff and the people that we serve, with a goal to advocate for change that will move us closer to becoming an anti-racist organization. And it's important to say here, one of the reasons why it's so important to understand the definitions of diversity, equity, inclusion, and health disparities, and understanding the intersectionality of the many areas and components of those definitions, is that yes, we use the language anti-racist systems, anti-racist organizations, et cetera, but in using that terminology, it is very inclusive of every population that may be experiencing disparaging healthcare practices at any given time, regardless of race, ethnicity, gender, etc. Intentional and deliberate action. And of course, yes, the actions that we take are really the most important. And in acknowledgement, there has to be action that occurs afterwards in order for change to occur. You have to have a vision and a mission, a model of care that's inherent in anti-racist practices. Many of us may have this idea in mind and in hand, but it possibly could be hindered as a result of racist organizational infrastructure that exists. Of course, you know your organizations, you know your organizational structures. I know that nursing homes often have varied organizational structures. Some of them have corporate structures. Others may have smaller organizational or corporate structures, and some are even private, not-for-profit, private, small nursing facilities with one owner, family-owned, et cetera. So they vary in that organizational structure schema, but regardless, leadership has to be involved in the acknowledgement, in the desire and goal setting, and in the actionary plans that are implemented to make changes and work towards becoming truly anti-racist organizations. And becoming an truly anti-racist organization will require perseverance and a lifelong commitment by leadership and all staff. It will require nursing homes in particular to have the commitment from all leadership to make the changes that are necessary in this particular area. And this is just a demonstration of how to start with these type of actions in your communities. As the work begins and continues, there are things that must occur and be incorporated in the process to meet any level of success. I'll highlight and note, this is not easy work. My colleagues and I have been working in this space diligently since I've been at Traeger. I'm sure they were working in this space before, but after the pandemic and the social and racial unrest in our country in 2020, I think there was a renewed commitment to actually put some things in action. And I can openly say here that it's not been easy, but it has been consistent, persistent, and ongoing. And one of the ways, or some of the ways that you do this to make sure that we're able to implement intentional and deliberate action is, again, define the problem and set clear goals and objectives. Intentional and deliberate action. Clear goals cannot be set without defining the problems that exist within the organizations. This is not a stagnant step, but is a fluid process that can utilize various tools to facilitate addressing racism at various levels. There are literally anti-racist or diversity, equity, and inclusion tools that can help you to assess components of your organization, including your policies and procedures and practices, to give you a area or an understanding of what some of the issues or concerns or problems even with those policies might be as it relates to diversity, equity, and inclusion, as it relates to racism, as it relates to not being an anti-racist organization. I'm going to be sharing some of these tools, or the ones that I'm aware of, with Justin. And when he sends out his email to you, you'll have links or copies of a few of those tools that may be applicable in your own environment. There is a suggested example that's listed in the footnote of this particular slide that you can go to. A suggested example here could be the diversity evaluation, also that many of our students use with the different provider sites that they work with, and we'll be sharing that with you as well. But at the end of the day, we cannot mince words, but must call racism what it is. Racism, oppression is what it is. Oppression is oppression. And many populations within our healthcare system, as well as within our nursing facilities, do experience oppression in various ways. Leadership buy-in is very, very important, as well. As you see in that third bullet. Without buy-in and commitment by leadership, change cannot occur. Talked a little bit about that just a few minutes ago, as we talked about organizational structure and the importance of knowing that organizational structure. And one thing I'll reference about organizational structure is that if you are within a larger, if your nursing facility is within a larger corporation, organizational group, just knowing, getting information and knowing about what your leadership is doing or has done in the space of diversity, equity, and inclusion can be very beneficial. Even if there's nothing being done, at least you know that you've acknowledged that there is a lot more work to be done. And if they are doing some things, if they have, for example, a diversity, equity, and inclusion office, or a staff person who is heading that up, then you can actually reach out to them to find out a little bit more about what you might be able to do in your own facility. Funding and resources is another area that's really important. Dedicating specific funds for serving in this particular area, for helping and assisting, for possibly even bringing in support and expertise to help you to learn more about your particular environment, your nursing facility, and the people that you're serving as it relates to diversity, equity, and inclusion. And then just making sure that the work that you're doing, the things that you began are ongoing, and that they're meaningful to the community and the people that you're serving, that they are included in the process of what you're doing in the area of diversity, equity, and inclusion. It is important to establish strong relationships with diverse groups in your nursing facilities, with the patient populations, the different populations. And in order to do that, you need to know what those populations are. It's important to be able to know and understand who they are and what matters most to them. Back to the 4 M's always. All right. So intentional deliberate action requires action at every level: policy level, organizational level, the community level as well. You know, all nursing facilities are communities, but they also exist within a community. So knowing and understanding and taking the necessary action in those areas is very important as well, interpersonal level and individual level. Remember, this is a journey and the pace is sometimes slow. It's a multi-level approach that must be taken, must be used to address racism within healthcare organizations. Sustainable change does not occur with one-time intervention that only focus on one area or level of organizational structure. This is a marathon, not a sprint. Sustainable anti-racist practices occur when there is intentional and deliberate action of anti-racist design at the policy level, organizational level, community, interpersonal, and individual level. There is no quick fix. Leadership must be committed to not engage in tokenistic decisions, changes, and practices, but must utilize intentionally anti-racist intervention to influence change. And we all probably can name several since 2020, sort of tokenistic acknowledgments, even practices that have occurred, maybe not in your own organization, hopefully, but maybe there, but just nationally. You probably remember so many companies came out with these DEI statements, we're going to stand up for justice, et cetera. Many of them made them public. But what have you heard from them lately? Where are they now? That is not what we're going for. And I can't emphasize enough that we have to be patient with ourselves as we work in this space. We have to be patient. And sometimes, depending on your organizational structure, that the individual level is the first level that you start at, and you may be working in that space for a very long time, because not every system is ready to move positively in the direction of becoming an anti-racist organization. Alrighty, I'm looking at my time. Good. This particular slide is really just helping us to understand accountability. That is that third prong in that diagram I showed you earlier of system change, is that after acknowledgement, taking action, then you have to be accountable. Through work that we've done at the Traeger Institute, we've worked in some very specific spaces, and I'm letting you know this work is continuing on. We've not met our goals yet, but we're pacing ourselves and working towards our goals. But it is a multi-directional work when you're doing this work. This is just demonstrating that at Traeger Institute, we're hoping to have a very robust and open health equity plan, health literacy plan. And in doing that, we've acknowledged that we need to do that. We are putting into action the things that need to occur for us to reach that goal. But in doing that, action also has to take place in the area of advocacy, and we have to continue to review and assess. There are various examples of acknowledgement, action, and accountability that facilitates change in the right direction in long-term care. One of these areas that I want to emphasize today is related to age-friendly health systems. The John A. Hartford Foundation and Institute for Healthcare Improvement, who started the age-friendly health systems movement, are also engaging in systems change as it relates to diversity, equity, and inclusion. Here are some of the things that they did. They created an equity task force in 2020, and they began this initiative with a focus on measures and data collection. They encourage health systems like yours, like ours, including nursing homes, to record racial ethnic breakdown of patient population. And this is just really a straightforward example of something that any of our healthcare systems can begin doing today or tomorrow. So you first start with recording your racial ethnic breakdown of patient populations. Then you link this collection of data to quality measures such as admissions, length of stay, patient family experience. Dr. Yankee Love talked earlier during our session today about the advanced care plan, for example, identifying the number of your patient population who actually have an advanced care plan on file, and then relating that data back to your racial ethnic breakdown and data. Population can inform you immensely about what's going on in your nursing facility as it relates to who has an advanced care plan, and maybe even understanding why or why not as you continue to uncover and peel that particular area of data. And then you analyze those outcomes, stratified by race, ethnicity, and then take action to address the disparate outcomes. So putting it all together, as you heard several times probably during this presentation, because I said it several times, acknowledge, action and accountability, acknowledgement does require assessment. In an area you can start also, other than the example I just gave you from IHI, is to look at your policies and procedures. You can assess your policies and procedures and then create where you've identified possible issues with diversity, equity, inclusion, any health disparaging practices, etc. Create a plan for change and action. And then you continue to review your changes and address the issues that were uncovered ongoing until you reach the goal that you desire as it relates to that particular area and situation. Ultimately, our goal is, we know we have succeeded when diversity for everyone is having a seat at the table. Inclusion is having a voice, and belonging is having that voice be heard. So with that, I'm going to stop here and ask if there are any questions, or if there are any, if anyone would want to share examples of things that you may be doing in your own nursing homes in this area. Anything, please share. Don't know if anything was in the chat. Any questions, examples? Justin asked a question: what would be an example of a racist organizational structure? And I think it was, I can't remember who it was in our morning session, but they did give a description. It might have been our ombudsman of situations where nursing facilities didn't accept certain residents because of who they were. It could be related to race, ethnicity. It could be related to sexual orientation. It could be related to other things as well. That practice, although it may not be integrated in their policy, is integrated in their practice and their culture. And that's an example of a racist organizational structure.
Yeah, I remember that, Barbara, we were talking about admissions policies and whether or not the admissions denial was really for the stated reason that was given, or if there was something underneath that.
Right.
That rock metaphor is really resonating with me right now. I think these are really hard things to look at. And so I would even just ask the group a general question of like, well, how does this hit you? Because my first reaction to a lot of this is, oh yeah, that happens other places, not here. And I think there's a certain, I'm going to call it a knee-jerk reaction on my part to be like, yeah, that's other places, that's not us, because we have a DEI committee and we meet regularly and we have a statement. But that's just like what you were describing, Barbara, is that's just like really the littlest, tiniest little bit of a start on things. So I'm wondering if other people are feeling the way I am, that it's a little hard to look under the rock. I like that this is kind of a community where I can say that kind of stuff, like true confessions, you know?
And I appreciate what you said, Chris, because it is hard to look under the rock. But I do think I really appreciate the approach, that simple approach that IHI provides because I think if we're informed by data, that is more palatable. You know, we're able to accept it a little bit better, but it also gives us a place to start and begin to, I like to call it peel the onion, because none of this is simple. It's all very complex. And we don't always know where to start. We don't always even know how, to start with understanding our own environments and organizational culture as it relates to DEI. And really, the first instinct is often to say, well, that doesn't happen here. That does not happen here. But we had a few examples this morning where I do believe that some of what we discussed really resonated with them as it relates to, well, I didn't think of it that way initially, but you know what? That's probably what's going on here.
Yeah, like a uh-oh moment. Do you know, I like
Yes.
what you're saying about data, Barbara. I have a love-hate relationship with data. I mean, data's always,
Don't we all?
ooh, well, we could talk. We should talk. But some of this stuff is like feelings too. I mean, it might not show up in the data. Can you talk a little bit about acknowledging the feelings even if the data doesn't show it? Do you know what
Right.
I mean?
Yeah. Well, another thing that I want to share that I think is really important, and I tried to give this context early on and throughout this presentation, is that yes, as soon as you say diversity, equity, and inclusion, when I use the terminology anti-racist, et cetera, I do think people navigate to this, race, ethnicity, Black and white, et cetera. But it's so much more than that. It is so much more because, I believe if we make sure that we have anti-racist organizations, that we are creating a culture and an environment that is inclusive of everyone, regardless of their race, regardless of their ethnicity. In Kentucky, for example, there are many nursing facilities that in parts of our state that don't have any minorities whatsoever, but there could definitely be disparaging practices. Sometimes it's systemic as a result of our overall national systems of healthcare, and sometimes it could be culture as it relates to that particular nursing home. And I'm gonna give two examples. Both of these two were shared this morning. Justin talked about the social economic differences, and I referenced that earlier too, with the difference between payer source. Sometimes nursing facilities that accept, when I worked in the field, we always talked about, we need to find a Medicaid nursing facility. My client has Medicaid. Where's the Medicaid facilities? And the family is saying, no, that particular facility, we know as a community that facility doesn't, have issues, have problems. I'm not going to say doesn't serve well, but that difference in payer source has a significant impact on the type of care, whether we like it or not, whether we're working very diligently to try to make sure that doesn't happen or not. It has an impact on the care that a person receives. And when within that nursing facility, not everyone or most are not paying attention to that particular fact. But that community, that family, and probably every person in that facility know that their nursing facility is different from that one on the other side of town because of the payer source. That's one example. Another example is the one of the facilities this morning shared with us that sometimes it's the resident themselves who who have the issue and may be using racist language, et cetera, towards other residents who are different from them, maybe even towards staff who are different from them. What do you do with that? Now that's not a feeling, that's a real thing that happens. And many staff probably don't know what to do with it, or maybe they've not addressed it openly in that facility. And the thing that I shared this morning, because again, that's a really deep, heavy topic that probably requires a lot more discussion, is that the first thing that you have to focus on in that space, and this is part of becoming an anti-racist organization, is to make sure that none of your residents are re-traumatized, including the person who might be of a different race from the predominant race in the facility that one or more residents are aggressively speaking towards as it relates to those races. And it is 2:57. We have 3 minutes to finish up. I'm going to advance to the next slide, but if there is any questions or more comments, suggestions, information you want to share, you can do it in the chat. And of course, we'll stay over after 3 o'clock to give you space to continue the conversation. Justin.
Thank you, Barbara. And I don't know why that duplicated twice, but it put the session 23 is going to be on assessing and addressing health disparities and social determinants of health of nursing home residents. So if you'd like to submit a case or you have any questions, please submit a case. There is the case submission link right there, and there's also the QR code on the screen. And if you'll advance to the last slide, please. So, I'm sorry, the slide before that, sorry. Go back to the QR code. There we go. Thank you. And here is the link for session 22. So please complete today's session survey, and we appreciate you being here, and we'll be on if you have like to stay around and ask some questions, and we hope to see you next week.